Good afternoon, friends, and welcome to this session on new technologies in spine surgery. I talk a bit about current application and navigation in deformity surgery and how it's helping us. If this goes back. Oh, yeah. Thank you very much. Just a grateful acknowledgement to some colleagues for their input, no disclosures. Spine deformity has a big impact on quality of life, as we're all aware, and it's one of the 4 main chronic conditions that can severely impact patients' lives, as per this ESSG paper. But there are problems with regards to the treatment of spinal deformity surgery, in that the complications can be as much as 80 to 100%. The procedures are much longer, there's longer skin incisions, increased radiation, longer procedures, and all sorts of complications, right from mechanical to medical. But what I'd like to talk about today is mostly about increased radiation and what navigation can do to help. Why perform spinal deformity surgery? We also know that people who have procedures done to improve their quality of life are much better in terms of requirements for medication for pain. They can achieve normal activities which they could not have done when they were in pain, and they can have a little normal active life as opposed to others who have not had these operations as per this paper. In the past few years, there's been remarkable growth in spinal surgery, as we know from the amount of procedures as also the publications. And the advances are mostly in understanding the pathology, in implant sophistication, imaging in terms of MIS, navigation. But as the frontiers are pushed, technical dependence grows and it becomes more and more complex in trying to improve patient outcomes. But there are growing surgeon concerns. In the last few years, we have, as a fraternity, talked about the problems that we face as surgeons in terms of the problems we face while performing our activities for patient care. We have problems with radiation, physical issues, burnout. In a talk from SRS Barcelona, I was told that 60 to 70% of neurosurgeons in the US end up having a posterior foraminotomy because of neck pain and arm pain. There are problems with back pain, shoulder issues. But my concern today is about increased radiation, which we've had to face in the last few years while performing our activities in deformity surgery because of the increased number of pedicle screws that we put. Some data here, not just in spine surgery, but also cardiologists and the nurses, find that there's increased signs of cataract because of the exposure to radiation. And orthopedic surgeons are 5 times more likely to develop cancers because of radiation exposure as opposed to other physicians, which is a bit worrying. But even more worrying is the fact that we as spine surgeons have 10 to 12 times the amount of radiation exposure as opposed to our other orthopedic and other colleagues in surgery. And the other worrying problem is, for me, that the amount of exposure we receive in the first decade of our careers, which is for nearly most of us has already passed, is much more than other surgeons receive in the whole of their career, which is a big problem. Thyroid shields can protect only about 60% of radiation, but not all of it. What is the best practice in terms of radiation exposure? ALARA is as low as reasonably achievable, but the poor quality image that is available with this kind of repulse image cannot lead to good scientific and surgical approach. What can we do to reduce the risks for patients and surgical teams? I'm talking not just about surgeons, but also about the nursing staff we work with. We can increase lead protection, but then again, it uses only about 20%. And we can use CT-based navigation system, which we have been using for the last 10, 15 years, where the surgical team moves out while the images are being acquired, and that way the radiation exposure is much limited. What can we do then to use the new technologies for better results, less complications for patients and for ourselves and the surgical team? We also know that spine surgery has evolved to less invasive and more advanced procedures, the thrust being on clinical care, operational care, and financial constraints. And what can we do? These new challenges come along with OR time, implant stability, radiation exposure, all need to be talked about. But then, navigation by itself is not just something in isolation. There are enabling technologies that help with achieving all of these impacts. And they are surgical software planning, computer-assisted navigation, intraoperative neuromonitoring, and now robotic systems. There's integrated workflow where all these come together in one theater to help improve our outcomes. And the evolution of enabling technology has gone from freehand fluoroscopy to 2D to 3D navigation and now to robotics. Increasing implant efficiency and accuracy, as we know from the slides I'm showing here, fluoroscopy was about 85 to 93% accuracy, but had radiation. Navigation has gone on to about 94 to 96%, with not much in terms of radiation, and robotics now is about 99% accurate with no radiation at all and less complications. So we're moving forward in terms of enabling technologies where the integration of all of these has the potential to maximize safety, consistency, reliability, and increase efficacy of surgical procedures. This involves smart imaging and reduction of radiation, which helps reduce it to normal as opposed to the standard radiation which used for fluoroscopy. So unfortunately, there are a few issues with the slides. The literature overview in the past showed that many papers, they don't talk much about usefulness of screw placement, but talk much about the consensus in terms of improving the quality of navigation or the pedicle screw placement. For me, the indications of navigation are a secure pedicle insertion in areas where the screw, the pedicles are quite thin, where there's problems with pedicle orientation, especially in revision surgery and controlling bone growth. But preoperative planning is mandatory in these cases. We have to know that the patients already have problems in terms of thin pedicles before we start. This is a nice example of small pedicles using navigation, where you use freehand in some of the pedicles, and you can use navigation in the pedicles that are more difficult to treat to get a better result. I've chosen this case. For example, I've lost the AP images in the uploading of the images, where this procedure was performed by 2 junior fellows just last week in my hospital, and the pedicles themselves are quite poor. The fellows performed the procedure with very minimal supervision to show that there is benefits to navigation, but there is increased radiation. So this is what they performed. This is what they, I think I've lost, yes. So they used a drill guide. We've lost the pedicle video, where they were able to perform with minimal exposure to navigation. They were able to achieve a reasonable rate of accuracy in terms of both the pedicle guidance as well as the navigated drill guides. The navigated drill guides also are useful in reducing surgeon burnout in terms of repetitive arm and wrist movements to put in the screws, do the tap, do the pedicle finding, put the screws and put the tap again. And now using a navigated drill guide at a low speed can be as safe as using freehand drilling. This is the results that they have achieved intraoperatively, which is not bad at all, considering they had very minimal experience in terms of navigation, which shows that navigation is actually quite good in terms of accuracy as well as reducing radiation, both for the patient and as well as for the surgeons. In conclusion, I think this is a good thing going forward, but the integration of all these workflows will improve the accuracy, which is inevitable. Thank you very much.
Thanks a lot, Shah. If you can stay on the podium for questions. I don't see the question-answer pad anyway. Is there any question from the audience about radiation exposures and navigation in deformity surgery? I do have one to you, Shah. Is about ergonomy. I mean, you are talking about cataract, radiation exposure, whatever. What about lead apron? I mean, I'm very happy to use navigation since more than 10 years now, not to be forced to wear this very heavy lead apron. My back is very happy. What about yours?
I think even in my own career, I've seen surgeons not using the thyroid shield for many, many years, but now more and more of us are using radiation. I use the skirts when I have to do the operation because there are less effects on my shoulders. But I think with navigation, we don't usually need to use any protection at all because all of it is now done very safely. When the image is being acquired and there is a spin going on, they're not in the same OR, so that means you may not need to wear any protection at all.
Absolutely. Any question here from the podium? If it's not the case, thanks a lot, Shah.
Thank you.
No, there is one on the left. Sorry. Please introduce yourself.
Yeah, Marek Rocowski from Gdańsk, Poland. I'm also a big fan of navigation during adult spinal deformities surgery, but there is always a question, and it is they're questioning me also about it. What about the patient's safety and radiation dose to the patients? Because we can go out during the arm scanning, but what about the patients?
I think, of course, I mean, there are, I have lost a few papers in that presentation. There are studies now show that the pulse frequency, which is a low dose, brings down the exposure to almost 90 seconds, which is much less than what it was with fluoroscopy. So there is a reduction in terms of radiation already. And once you do have the spin, you may not need to have any other further imaging exposure. So then there is, for the patient as well, their benefits.